If you're starting dialysis, you probably already heard about something called an arteriovenous fistula. I'm going to explain to you what is an arteriovenous fistula, why it's important, and how a newer, minimally invasive option called a percutaneous arteriovenous fistula might be a great choice for you. An arteriovenous fistula is a connection between an artery and a vein in your arm. It gives us a safe, reliable way to access your blood for dialysis. As you know, hemodialysis is a process where we remove the blood from your body and filter your blood through a machine to replace your kidney. And then the blood is, of course, infused back again in the circulation. But how can we remove the blood and then put it back in? Well, you need an access for that. And nowadays, there are two options. One, you can have what's called a dialysis catheter, which is a tube that we insert into a vein, usually in the neck. And it has two parts, one part to remove the blood and the other part to give the blood back. Now, the problem with the catheters is they cause many problems long-term. They often get infected. They also can destroy your veins long-term. So it's not a good long-term solution. The other way to do that is to create an access that is a blood vessel that is superficial that you can cannulate with a needle every time you do dialysis. But it needs to be superficial and needs to have a very high flow, much more flow than your normal vein. And to make it simple, there are two ways of doing that. You can either make what's called an arteriovenous fistula or a graft. A graft is essentially a plastic tube that you connect to the artery and to a vein, and you leave this plastic tube under the skin, but it's very superficial. Now, a graft can be a good option for some patients, but it also has problems. It doesn't last very long, and they also can get infected. Now, in this day and age, the best dialysis access a patient can have is a native arteriovenous fistula. An arteriovenous fistula is a connection between an artery and a vein in your arm, and this uses your own veins with no foreign material. You see, because you connect a vein to an artery, will give a very high blood flow in that vein, and with time that vein will dilate and become very superficial and easy to be accessed. And this will give us a safe, reliable way to access your blood for dialysis. So this connection lets your vein grow stronger and handle high blood flow that the dialysis requires. Traditionally, arteriovenous fistulas are created through surgery, where they make an incision in your arm, like a cut, and then they can clean the vein and free the vein and then connect surgically with stitches to an artery. And of course, although it's a small surgery, sometimes it can be problematic because patients that are already sick with renal failure may have trouble healing. Also, when you clean up the vein, sometimes you damage the blood supply to that vein, and that can cause the vein to be narrowed and cause problems in the future. There are also risks like any other surgery, including risks related to anesthesia, risks of nerve damage, and risk of bleeding in the site. But now we have a less invasive option. It's called a percutaneous arteriovenous fistula. And the whole procedure amazingly can be done to one or two small needle punctures, and therefore no incision, no stitches, and faster recovery time. Not only this is easier and you don't have to go through any of the healing problems, but these fistulas may also have better long-term outcomes. And that's because there's less manipulation of the vein, which stays in the same place, and hopefully patients don't develop scar tissue problems. But creating a connection between an artery and a vein without making an incision, how is that even possible? Well, there are two devices that are FDA approved. The first one is the Dialysis system. In this procedure, we use ultrasound guidance to introduce a very small needle through a vein in the elbow, and then we navigate with the needle under ultrasound guidance through the vein until a point where the vein is very close to the artery. And then we can basically puncture the artery with that same needle and make a connection. We introduce a wire into the artery, so you have a wire going through the vein and into the artery, and over that wire we place the device, and when we close the device you bring them together, and using heat and pressure we create a connection. And with the Dialysis system, the entire procedure is done with a single needle puncture, essentially the size of an IV. The second device is called the WaveLink system. This device requires two needle punctures. We usually make a puncture in the artery in the upper arm and a puncture in the vein in the forearm. And through these punctures, we introduce small magnets one from the artery and one from the vein, and we find a place where the artery and the vein connect. Once these magnets close together, we use radio frequency to make a connection between these two tiny punctures. It's a very smart device, right? Both of these procedures can be done as outpatient, and they may take less than half an hour to do. They can be done with a local anesthetic, but most times we use twilight sedation, where you inject medication in your IV so you can relax, and you probably won't remember the procedure. Once the fistula or the connection between the artery and the vein is made, we then can use the ultrasound to check the blood flow, and we can see with color how much blood flow there is. The flow should also be turbulent because it's going from an artery to a vein. And we can actually measure how much flow is going to that fistula at that time. We usually want at least about 200 mL per minute of blood flow going to that fistula during the initial creation. And of course, once that fistula matures, which means the vein grows, the flow will increase over time. So once it's all done, we'll hold pressure for a few minutes, and then we'll put a small amount of surgical glue, or what we call a liquid Band-Aid, at the side, and that's all. You don't usually even have a bandage. There's no stitches, and you'll be able to go home in the same day. So what to expect after the procedure? Most of the time, patients don't have a lot of pain. Of course, can be a little sore at the procedure site, but most of the time, pain medication is not required. You may have bruising, which may get actually worse over the next couple of days, but will disappear in a few weeks. You can also have mild swelling at the procedure site, which will also gradually get better within a few days. Immediately after the procedure, your hand can be a little numb from the local anesthetics that we use, but that should recover within an hour. You may also be able to feel a vibration, which we call thrill, in your arm at the side of the fistula, and this can be a good sign that the fistula is working well. But if you don't feel it, don't worry, it will come over time. Once you go home, you should be able to resume your normal activities by the next day. And we recommend to start hand exercises right away, like you can get one of those squeezy balls to actually increase the blood flow to that arm so the fistula can mature faster. In most cases, we'll do a second small procedure 2 to 4 weeks after the initial creation. And in that procedure, sometimes we use a slightly bigger balloon to increase the opening and make sure the fistula matures faster. We will also check the outflow vein to make sure there's no natural narrowings there that may limit the maturation of the fistula. And by the way, maturation process means that the vein's gonna get bigger, and also the flow through the fistula is going to increase. We usually require around 700 mL per minute of blood flow into that vein so the dialysis can be performed. And again, this second procedure, also called a maturation procedure, is a really simple procedure that only takes 15-20 minutes, and you also go home the same day and resume your activities normally. This maturation procedure is also done through a single eye. What are the risks of this procedure? The risks are very low, but like any procedure, there's always a possibility of a risk. The risks would include bleeding. Like I mentioned before, there can be some bruising at the site, and that's considered normal. And the bruising sometimes can get worse over the next few days after the procedure before it starts getting better. However, the swelling should be getting better after the procedure. It becomes problematic when you can feel like a lump or a ball growing at the site, which is called a hematoma. That can mean that the bleeding can be a little more severe, and if that happens, you need to let us know. Infections are really rare because we don't use any foreign or prosthetic material for this procedure. I think the main risk with these procedures is that this fistula may not mature. Overall, the success rate of these procedures is about 70 to 80%. Success means that you can successfully use that fistula for dialysis. In our practice, we usually are able to use 75% of these fistulas that we create. That means 3 out of 4 patients that we do these fistulas, they are successful. And these numbers are very similar to the numbers with surgery, like we mentioned before. Again, I just want to make very clear that with any of these fistulas, even surgical or percutaneous, there is at least a 25% chance that it may not be successful. What if the fistula does not work? So also, I mentioned before, we usually need at least 700 mL per minute of flow to be able to do dialysis, although some of these fistulas, the flow can be up to 2 or 3 liters. We can measure the flow with a simple ultrasound that can be done in the office, and we'll follow you after the procedure to decide when the fistula can be used. Most of the time, the maturation period is 2 to 3 months, but it could be shorter or longer depending on the condition of your veins. What do we do if the fistula doesn't mature? We still have other options, right? Sometimes you can convert a percutaneous fistula to a surgical fistula. Now the vein that hopefully will be a little bit bigger, it may be even easier for them to do the surgery and connect to an artery to a different connection. Or sometimes the problem is that the vein is good, but it's just too deep. And you may require a second procedure to superficialize that vein to make it closer to the skin so it can be accessed during dialysis. We also sometimes one arm is just not suitable and the vein may never develop, and if you don't have any other vein, we can try the other arm. And some patients don't have any veins or they run out of veins after multiple procedures, and the only way to create a dialysis access other than a catheter may be to put a prosthetic tube under the skin, which is called a graft. So we do have many options, and the most important thing is that you continue to work with us, with your nephrologist, and potentially with one of the surgeons in our team as well. Now, if you're already having dialysis with a dialysis catheter, of course, we don't remove the catheter right away. We will wait until the new fistula is fully functional before we'll remove the dialysis catheter. And that means we will actually wait until they can use that fistula for several sessions before we consider removing the catheter, because we obviously don't want to have to put it back in, right? Now, not all patients are candidates for this, right? We need to make sure that you have suitable veins and a suitable artery to create the fistula. And the way we find out is with a simple ultrasound with the arm. To be a candidate for this procedure, we usually require a patent artery that is more than 2 millimeters, and usually at least one outflow vein that is bigger than 2 to 3 millimeters to be able to make this procedure. Essentially, in my opinion, percutaneous arteriovenous fistulas are a big step forward in the dialysis care. They are safe, effective, and far less invasive than the traditional surgery. So if you think you may be interested in this, talk to your nephrologist or contact us and we'll do an ultrasound and evaluate to see if you're a candidate for that.